Hello, everyone, and welcome to the Root Causes of Mental Health, where we discuss how to identify and treat the hidden root cause drivers of chronic mental health problems. I'm your host, Dr. Bruce, the founder of Potomac Psychiatry, and today's guest is a true pioneer in the role of how infectious diseases and the immune system are implicated in causing many mental health conditions. He is a highly accomplished scientist, a serial entrepreneur, and is a valued mentor to me. It is a true honor to be able to have him join us today. And with great pleasure, I introduce my mentor and friend, Dr. Craig Shimasaki, who's president and CEO of Moleculera Biosciences. Dr. Shimasaki is amazingly accomplished. He has a PhD in molecular biology and biotechnology, as well as an MBA. He's adjunct professor at the University of Oklahoma and is the co-founder and CEO of Moleculera Biosciences, a neuroimmunology precision medicine company focused on identifying and treating the underlying root causes of neurologic, psychiatric, and behavioral disorders triggered by an autoimmune response. Dr. Shimasaki started his career at Genentech, where he worked across all stages of research, development, clinical trials, and regulatory approval of technology innovation from bench to bedside. He has co-founded numerous companies and is a co-inventor on multiple patents. Internationally, he teaches and mentors scientists, physicians, and biotech leaders on how to translate their research into urgently needed medical interventions. His passion is to translate scientific discoveries into acutely needed products so that more patients can live longer, healthier lives. And he's had a huge influence on my practice of psychiatry and that of my colleagues. Welcome, Dr. Shimasaki. It is a great honor to have you join us today.
Thank you, Dr. Bruce. The feeling is mutual, and I am always amazed at how you're pushing the envelope in understanding how these disorders can be connected to psychiatric symptoms, and more importantly, how to get these patients well rather than treating symptoms. So my pleasure to be on this here with you.
And I think today will be a real eye-opener for many of our viewers who are suffering from chronic mental health conditions, where they come to learn that it may have all been triggered by an infectious disease. So with that in mind, let's jump into some questions that we can help answer. First, how are infections and the immune system tied to psychiatric conditions? And how big do you think this problem may be?
Yeah, that's a really, really important question because, we're always exposed to different infections. And I think the telling thing that opened the eyes to a lot of individuals in the world was SARS-CoV-2 or COVID, because long COVID is the manifestation of an infection being able to trigger the immune system and in certain people cause it to become dysfunctional. So that the immune system begins to attack parts of the brain, causing brain fog, fatigue, the cardiovascular system, causing other types of abnormalities and other organ systems. But what we do know is that infectious triggers in certain individuals predisposed to immune dysregulation can result in the development of these different types of neuropsychiatric, behavioral, and mental illnesses, of which we call them that. But in reality is an underlying biological condition that is treatable.
Yeah, I think you make an incredibly great point that in our world, infection-induced neuropsychiatric problems is not a new phenomenon. And I know for years, people like yourself and Dr. Madeline Cunningham and Dr. Susan Suedo and others have been trying to get the world to kind of wake up to this fact. And then, hate to say it this way, but COVID actually has helped with all of these patients that we've seen with long COVID symptoms of brain fog, depression, and anxiety, where it was the result of an immune system triggered autoimmune condition that originated with the response to the coronavirus.
Mm-hmm. You mentioned, how big is this? And really, if you kind of look at, let's call it autoimmune disorders in general, many of them you can find associated with at least suspected infectious triggers like chronic fatigue, EBV, HHV6, and you see even things with Sydenham chorea which is the neurologic manifestation of rheumatic heart disease, which is triggered by a strep infection. You look at many of these other disorders that you can see connected with myasthenia gravis and other things that are different, really different targets of the immune system, but there generally is a trigger in which these things are seen. Even you look at lupus and the potential identification of triggers like Epstein-Barr virus. So this is very large. There's over 100 different types of autoimmune disease categories. And we kind of would be thinking really of these immune-mediated neuropsychiatric disorders as sort of a version of an autoimmune condition, which is really not what we think of as autoimmune, but really the terminology auto meaning self and immune meaning the immune system. It's just this self-detection or direction of these immune system. And in some cases, the one we're looking at here, these immune-mediated autoantibodies. So the market, or I should say the population that's affected by these disorders is really huge.
Well, what it really calls for is a paradigm shift in how we think of many patients who are suffering from chronic mental health conditions, where let's say their family members or friends say to them, well, what's wrong with you? You have a great life. You shouldn't feel this way. You should snap out of it. And yet, as you and I know, many of these patients have antibodies that literally attack the brain. And, there's a wonderful article. I really give him enormous credit for the amount of work that he put into it. Dr. Robert Bransfield published an article in December, just a few months back, called Microbes in Mental Illness, where he identified something like 40 different microbes that can trigger mental illness. Some of them you mentioned earlier. And I think what it calls for is really a shift in the paradigm of how we understand these conditions as really brain illnesses that have a large immune system component to it. And one of the things you and I were talking about before we got started today is the microglial cells in the brain. A lot of our viewers probably don't know that, think of neurons and synapses. That's what's in the brain, but there's a whole glial cell system in the brain, 100 billion of these glial cells in the brain. Many of them are immune system cells that start to get activated in response to these viral or bacteriologic related infections. And then we see symptoms. So
I was going to add to what you're saying there. The glial cells are the immune system for the brain. And so again, we're talking about another immune system dysfunction that contributes to it. And I think the interesting thing is when people find how can infections really be associated with these mental illnesses or neuropsychiatric conditions, there's an interesting study that was published in 2019 in JAMA Psychiatry, in which in Denmark, they're able to follow people for the lifetime of their medical records. And these were over 1 million individuals who were followed and the medical records were examined. And what they found out was that if an individual is hospitalized between age of birth and 18, if they were infected and hospitalized for an infection, they were 80% more likely to be diagnosed with autism, schizophrenia, bipolar, chronic depression, ADD, ADHD, and other mental illnesses. So there definitely is an association, but what we're talking here really more is with how the biological evidence shows that, there's this molecular mimicry that goes on with an antigen in these infections that the immune system recognizes that's common to a part of the brain. And again, we're not talking necessarily in this case about, let's say, like viral encephalitis, where the infection is actually in the brain or an organism is in the brain. We're talking about the immune system being triggered such that the immune system is causing this interruption and damage, which is a different condition.
Well, let's connect the dots for our viewers. In your work in the thousands or even tens of thousands of patients that you all have studied, what are some of the common symptoms? Because when our patients come to us for treatment, they present with symptoms, right? They don't think, oh, I've got this immune system that's not working right. Oh, that could be what's driving the symptoms. But what are the really common symptoms that are associated with these infectious disease-induced immune system changes?
Well, and this really is the issue that confounds many of the diagnosticians is because often it's so heterogeneous. So in one patient, it might be brain fog. In another patient, it might be fatigue. In another patient, it could be motor and vocal tics. What are some of the things we do see that help in identifying them is typically a patient may be considered, let's call it normal or baseline for a period of time. And then something happens, whether it's sudden onset or gradual onset, that they begin developing maybe some type of anxiety or uncontrollable phobias or fears, or maybe even some psychosis. But generally, you'll see a large manifestation of different types of symptoms. And principally because in these conditions, we see that their antibodies are attacking the basal ganglia. And the reason I bring that up is because the basal ganglia is responsible for cognition, sensory and motor movement, cognitive and procedural learning, eye movement. And so when you see, let's say, difficulty focusing, brain fog, concentration difficulties, abnormalities in emotional ability, things like that, these all can be tied back to interruption in the normal functioning of that part of the brain. And so typically they could be a whole host of whether they be cognitive and developmental, apparently developmental types of symptoms or disorders, or they could be OCD. And sometimes there are even things that we might call that look like eating disorders, which is one of the hallmarks of PANDAS and PANS, but it's not so much of an identity issue. It's actually more of an OCD in which a patient has a fear of food contamination or a fear of choking, which is an OCD. And these types of conditions really are things that have come on really with either sudden onset or even gradual onset, or they might appear early in childhood and then they manifest in an adulthood and kind of stumps really the diagnosis of this without an understanding of how these immune-mediated disorders can trigger these symptoms.
It brings to mind immediately 3 patients that we've evaluated in the practice and treated. One was a little girl, 5 years old, who developed a relatively sudden onset of OCD symptoms. And she was evaluated. She was diagnosed with OCD, placed on an SSRI, and was treated in cognitive behavioral therapy. And she wasn't getting better. She was getting worse. And when we explored more with the mother, it turned out that this little girl had all these symptoms follow COVID infection in the family. And we referred her to a child neuroimmunologist, and she's placed on IVIG and did remarkably better. And then more recently than that, it was about a year and a half ago, we've now had 2 cases of men in their one in his late 60s, one in his 70s, where in the first instance, he had OCD, depression, anxiety, and Parkinson's-like symptoms, was evaluated at great centers, had no response to anti-Parkinsonian medication, had a deep brain stimulator implanted, got somewhat better. And then when we took a history related to infectious diseases, it turned out he'd had a severe Epstein-Barr virus infection. Prior to the onset of all of these symptoms, we sent him to a neuroimmunologist. We had treated him with some supportive medication, some antidepressant, anti-anxiety medication, again, helping some. Sent him to a neuroimmunologist who put him on a course of methylprednisolone. And when it reached 88 milligrams, all of the symptoms went away. It was like a cure. Obviously, you can't keep someone on steroids indefinitely. So, we're looking at some alternative medications. But can you describe, and I think it might help our viewers, if you describe the process from, okay, we get the infection and then there's this molecular mimicry. Can you kind of walk our viewers through all of that and then how it affects the brain and connect your thoughts for our viewers?
Yeah, and Dr. Bruce, you just described really why precision medicine is so important, because in this area of psychiatry and even mental illnesses and what we might call neuropsych, different types of behavioral disorders, the majority of all of them are diagnosed by the presence of clinical symptoms. and not biology. And so, but what we're dealing with is the difference in a biological etiology root. So to go back to your question, onset of an infection, which we all get, everybody gets infections. We deal with this, whether it's bacteria, virus, fungal, parasitic, we deal with them constantly. And normally our innate and adaptive immune system will respond accordingly to mount a response. And then ultimately our adaptive immune system will develop antibodies that are specifically directed against that target so that if we ever see it again, it's going to remember it. And the body will make memory B cells that will be stored for sometimes for a lifetime so that if we ever get exposed to that particular antigen again, it's ready to mount a response, which is why vaccinations came into being and helped lots and lots of people. But in certain individuals, and this is the key, there's a genetic susceptibility to this self-non-self dysregulation. And meaning you don't see a family history of neuropsych or mental illness in these families. What you see is potentially some sort of familial, let's say, could be lupus, could even be just psoriasis, could be asthma, could be some indication that the immune system might have a susceptibility to some dysfunction. And then what happens after the infection, these antibodies that they make are directed against a portion of these specific organisms that's called an epitope, which our body makes. But the epitope that they make it against is a part of the organism that's identical to a part of our body. And so because there's only 20 letters in the protein alphabet that we use, at some point, a segment of 7 or 9 amino acids are going to be identical to a segment of a part of our brain, let's say our dopamine receptors. And if your body makes antibodies to that, what's going to happen is then it's going to start searching around and it's going to find, another target that looks exactly like it. And in these cases, dopamine receptors D1 and D2, lysoganglioside, tubulin, and even this calmodulin CaMKII. So then what happens is a patient will then, post an infection, start exhibiting some of these symptoms. And then these symptoms, as you mentioned, will be tried to be controlled with symptomatic treatments. In the majority of cases, they're not that helpful, except for in their very, very low doses. And then what happens is often they'll be on a very long journey to try to find out what's wrong with them. And often we see cases of patients who have been searching for years, and a couple of them for over 2 decades, until they get properly diagnosed, the underlying root cause is treated, which is basically what your organization does, is that's, find the root cause for why do they have these psychiatric symptoms, and then let's deal with the root. So it integrates infectious disease, immunology, psychiatry, neurology, and this is part of the reason it's been a little bit of challenging in medicine is because of the specialization. And so this comes back to why I think root cause psychiatry is so important, because we see the growing numbers of mental illnesses, psychiatric symptoms and things that really a very large portion of them could be due to the immune dysfunction and be adequately treated.
Right. You refer to molecular mimicry as friendly fire, where sadly in wartime, warriors can turn on one another inadvertently, and the same thing happens inside our immune system, which, to your point, is programmed beautifully to attack invaders to keep us healthy and safe, but can turn on our own tissues to create a wide variety of different kinds of symptoms. And I think the genetic predisposition to this happening is beginning to be a little more elucidated around certain HLA genes, right, and MHC genes. One of the things that we think about, and I'd be interested in your perspective on this, is this question of why are autoimmune conditions generally, including the types that you're describing here, autoimmune conditions that attack the brain, why are these rising in modern society? And one of the things we see in our practice, in our root cause psychiatry practice, is these patients uniformly have problems going on in the gut. So not uncommonly, what do we see? We see not enough diversity of species of microbes in the gut.
Mm-hmm.
We see inflammation markers.
Mm-hmm.
in the gut. We'll sometimes see microbes that shouldn't be down there, pathogens. We'll see insufficient digestion of fats or fiber from the foods they eat. We'll see markers of leaky gut syndrome where there's a breakdown of the barrier between the gut and the bloodstream, and we're leaking into the bloodstream bacteria, bacterial fragments, incompletely digested foods. And then finally, what we commonly see is not enough so-called short-chain fatty acids. These are what help maintain and rebuild the lining, what's called the mucosal lining of the gut, to create that barrier between the gut and the bloodstream. So we see this in a lot of these patients. We also speculate, why is there more autoimmunity in our environment, right? There are more what are called xenobiotics, right? Things in the environment that weren't there 50,000 years ago, 20,000, 10,000, 5,000 years ago, but they're now in our environment. Do you have any thoughts? I mean, we love to speculate about all this. Do you have any thoughts about why we're seeing more of these phenomena today?
Yeah, that's true. We're seeing more of autoimmunity. We're seeing more of this immune dysfunction. And again, it is speculation, but some of these things, kind of surface around the hygiene theory is that in the US, we tend to try to appropriately have sterilization, sanitization, and especially is very important during COVID because of the transmission. But in the early years of an individual, when their immune system is developing and it's developing the self, non-self memory and learning what it is, sometimes what happens is they don't get exposure to these common organisms that aren't really necessarily as pathogenic, and they don't get exposed to them. We think about this with peanut allergies and things like this, is their immune system doesn't get trained in the sense where it is. There's a book called The Dirt Kehr. I think it was a pediatric neurologist wrote this. Her child had developed what was diagnosed as autism. And what she had gone on to, rather than taking all these medications, was beginning to grow these vegetables and using them, maybe not so much as cleaning and doing them in a way, and exposing the child to more of these different organisms. And consequently, as you mentioned, the gut. So what was happening is the population in the gut was becoming more and more diverse. And then what was happening, and this child no longer had these autism symptoms. So, there's a direct connection with the gut and the brain. And we know that a good portion of the immune system resides in the gut. And then the other is we do see that there is gut dysbiosis. When we do see that these different types of conditions in the brain occur. And one of the thought process and the speculation is that a very similar epithelial lining that lines the gut, very similar epithelial cells that line the blood-brain barrier, when there's an interruption in that, you do see both antibodies crossing the blood-brain barrier, but also different types of food and proteins crossing the gut. And then you see this gut dysbiosis and these allergies and these things like that. So, it's an interesting, really phenomenon, but we do see the growth in this. And one last thing is, if you go to these countries, let's say in third world countries, you don't see the numbers of these autoimmune and these immune dysfunctions and things like this, because it could be that they're exposed to more of these, let's say, non-pathogenic organisms constantly, and their immune system tends to be more robust. It doesn't mean they don't have any of these autoimmune conditions, but you look at the frequency of that and the numbers of these that are immune-mediated neuropsych, you don't see as many. And so that could be one of the reasons, is just the training of our immune system as we age or as we're young, and then what happens to the gut as a result of it that contributes to this.
Right. That all makes a lot of sense. And maybe to tie together for our viewers, when we lived in the wild and we ate a hunter-gatherer diets, we were doing a better job of maintaining a healthy gut microbiome while we were being exposed to microorganisms in the environment. And now we're not really doing a good job with either.
No, that's a really, really important aspect. And as you see that there is more research focused on a gut dysbiosis, what's the proper microbiota? And of course, there are some therapies, as we know, for, let's say, C. diff, for Clostridium difficile, a very pathogenic organism that is actually appropriately treated when antibiotics don't work with a fecal transplant.
Mhm.
And even some cases of like Crohn's and ulcerative colitis and things like that. So we definitely know that certain types of organisms that are more symbiotic in nature for us are important, and how they impact maybe the production of maybe metabolites or signaling to the brain and the vagus nerve is innervated in through the gut. And so there's a lot of theories of how an important, diverse, and well populated gut is important for overall health and longevity.
And from a mental health perspective, I think what could help our viewers understand it even more is down there in our gut with the 39 trillion microbes that live there, it's a huge manufacturing plant. Neurotransmitters, hormones, vitamins, short-chain fatty acids, more neurotransmitters are manufactured in the gut than in the brain. And if things aren't right down there, it will affect our entire body and certainly our mental health. I want to go back to something you mentioned earlier. I think for parents who may be watching, you mentioned PANDAS and PANS. And we're not talking about the pandas that used to live in the zoo here in Washington, D.C. Can you talk a little bit about what those are, PANDAS and PANS?
Yes, there are certainly acronyms that some of your listeners may be familiar with and many of them may not, although these terms have been coined for probably and have been around for a number of decades, which Dr. Susan Sweeto at the National Institutes of Mental Health at Pediatric Branch was the one, and her team, that identified it, which PANDAS stands for Pediatric Autoimmune Neuropsychiatric Disorder Associated with a Streptococcal Infection. And this was how she identified it, was presented with a number of cases of children that had sudden onset of these neuropsychiatric symptoms and OCD, and they happened to be all preceded by a strep infection. Now, she also noted that many of these other children that didn't get into that paper or that initial study had other infections, different types of infections. But because the desire to study a homogeneous population, PANDAS was coined. Now, as time went on, there was the recognition that it wasn't only strep, but mycoplasma, babesia, Bartonella, Lyme, CaMKII virus, and many of these other organisms were found in these patients that had almost identical symptoms, sudden onset, OCD, these different types of neuropsychiatric disorders, but they couldn't be diagnosed with PANDAS because it wasn't strep. And so this is where the term PANS was coined. And this is through the PANS Consortium at Stanford, and the group that got together 2015, 2017, published a large number of papers describing PANS, which stands for Pediatric Acute Onset Syndrome. And so that excludes any particular organism, or it could even be maybe some type of environmental organism. Now, this kind of leaves out the adults, unfortunately. What do the adults have? Well, they can't have PANDAS or PANS because they certainly aren't pediatric, but it doesn't preclude that adults cannot have a similar syndrome with a similar etiology. And this is a little bit where the evolution is occurring, because we do see a very large number of adults that see and respond to the same medications that you described. So it is an evolution of the recognition, a disease model that may actually spawn out into more disorders, such as parts of OCD, parts of ADD, ADHD, parts of chronic depression, parts of autism, things like that.
And we even wonder, could it be a third of the patients we're evaluating treating who have chronic mental health problems? Up to half? We don't really know. But that leads into, I think, a question that might really be important related to our viewers who may have chronic mental health problems, or a loved one that has it. How does a clinician screen for these infectious disease-related, immune system-related neuropsychiatric problems? And then in the screening process, let's say there's an index of suspicion, as we call it, that it may be going on. what might be part of the diagnostic workup?
No, that's a great question because early diagnosis really is the key because otherwise there's a lot of different treatments that are used that aren't, as you mentioned, may or may not be helpful. Plus, there could be some things damaging that goes on as the disease state continues. So one of the most important things for anyone and even the clinician that would look at this is a very thorough history, which you and your group obviously do. And there are signs in that workup in the history that is so important. The acuity of onset, maybe a reoccurring infection, maybe a waxing and waning or a relapsing, remitting type of a syndrome that is not necessarily characteristic of some specific type of disorder. Non-responsiveness to standard psychiatric medications that a patient with those symptoms would normally be responsive to. And you start seeing that, and then you throw in maybe the family history of an immune disorder. Then you've got this suspicious case here that you would say, I think this could be warranted for other testing. One of the things that we do have here is at Moleculera Biosciences, we do have a panel of 5 autoimmune target testing that we call our Autoimmune Brain Panel, which is formerly known as the Cunningham Panel, which I had previously named after my collaborating co-founder, Dr. Madeline Cunningham, who've done so much work over the years in this area, that this Autoimmune Brain Panel is a blood test that takes the serum of a patient and looks at whether or not there are autoantibodies that are directed against the dopamine receptor, the lysoganglioside, the tubulin, and stimulates this CaMKII activity. If any one of those are present above what would be normal, these patients really are candidates for diagnosis. And again, PANDAS and PANS and these other types of disorders that are immune-mediated are clinical diagnoses. So the identification of autoantibodies that are present is an aid in that diagnosis to be able to support the movement from, let's say, psychiatric medications to potentially anti-infectives, immune modulators, and anti-inflammatory agents. And this is really an important piece because so much can happen if a patient is not properly identified and treated for, let's say, years or decades later. And after testing over 15,000 patients and hearing all of these stories, because we don't have any salespeople, they have to really be looking for help. And they find us, and often it's usually after many years. But the interesting thing is, once they have been identified and the proper treatment is given, in the vast majority of these cases, we do see effective remission. And then even in many cases, in most cases, these patients have the capability of going back to baseline, which is amazing when you're thinking about some type of potentially a type of an immune-mediated attack on the brain.
And Moleculera has some wonderful data. You have those wonderful heat map charts where you can show the elevations of the antibodies to brain tissue prior to treatment. And then in those that get better, those patients get better, you see dramatic drop in those antibodies. And those that don't get better, you see continued elevations, which supports the value of the autoimmune brain test. We've been screening more and more for a condition you and I talked about a little bit before we began our session today, for mast cell activation syndrome. So here's something else where if we physicians don't ask about it, it's not going to be found, right? Which is really sad because so many of these patients have seen multiple doctors, they haven't gotten better, and the doctors are well-meaning and bright, but we only are trained in and trained to ask for what we're trained in, right? So with these mast cell activation patients, what's really confounding is they can have symptoms in multiple places that come and go. So these mast cells, which are a type of white blood cell, really don't stay in the bloodstream much. They migrate to tissues, and they can migrate to any tissue in the body. And when they're there, if they're overactivated, they release hundreds, maybe even thousands of molecules that can trigger all sorts of immune system related responses like cytokines that are pro-inflammatory or histamine, prostaglandins, and other molecules that trigger an immune response. And to your earlier point, the symptoms can wax or wane. They can go away and come back in a flare. Do you see any relationship between these activations of these mast cells and infectious diseases?
Yeah, you're right. And in fact, as you mentioned, they release these chemicals that stimulate or call on the immune system. One of them that most people know about is seasonal allergies and the release of histamine. And the histamine comes from these mast cells that are activated. And in the sort of the seasonal allergies, those that have them, 30% of the population in the US has them, is that it's mistakenly thinking as various types of common hay fever allergens as a danger to the body, and then releases these different chemicals in the mast cell, including one that's histamine. But yes, because it's an immune modulatory component, and in these patients that have these types of immune-mediated and infection-triggered disorders, often you can see this mast cell activation syndrome as a component of an additional burden to the patient that is on top of all these other things. And therefore, which is why this is challenging in medicine, is because you think, okay, well, I'm going to treat this part of it, but then this part is going on. And you may even see mitochondrial dysfunction. And so then you've got a loss of energy, you've got other things going on. And so it becomes really a complicated component. But if you look at it, they're all intertwined with an infection trigger and immune-mediated dysfunctional response. So one of the other things about mast cell activation syndrome, and is that they can have other types of comorbidities associated with it. So sometimes you might see maybe the diagnosis previously is Ehlers-Danlos syndrome or dysautonomia or POTS, postural orthostatic tachycardia syndrome. But some of these are other manifestations or comorbidities associated with it. And what we do see in patients that do have PANDAS and PANS, they may have POTS, where you stand up and suddenly you get this tachycardia syndrome. So again, immune mediated. And therefore, this is how it's important to identify it.
Yep. And it can be challenging to tease all that apart. So it brings to mind a patient we've evaluated and treated, and they had COVID and recovered from it, and then had undergone some pretty severe job stress with some resignations and some really difficult challenges. They have a managerial position, and then stress around the holidays, and began developing some depression and some panic attacks. And so placed this individual, I just want to be careful to preserve confidentiality. I won't give the sex of the individual, placed them on clonazepam.
Mm-hmm.
And it really began to help their panic attacks. However, it really didn't restore them to their old self. And then we did the screening for mast cell activation syndrome because, again, thinking COVID, post-COVID, immune response. So, this screening instrument we used for mast cell activation syndrome lit up like a Christmas tree. And so we began treating this individual with ketotifen, which is a mast cell stabilizer, and it blocks histamine 1 receptor. So it blocks that role of histamine triggering the histamine 1 receptor. And then famotidine, which blocks histamine 2 receptors. And it was like, bang, the panic attacks, the spells, the anxiety all went away. This is really fascinating here again that two medicines that modulate the immune system, basically, knock on wood, I think, have cured this individual.
So there's a question for you, being sort of an asthma medication there. Do you see that cromulin sodium, or do you use that in some cases when you see this mast cell activation, and is that effective?
We haven't used it yet. It certainly is reported in the literature as being effective. And the challenge is, you've got a really wonderful test there with Dr. Cunningham's test that she created in terms of identifying these antibodies to the basal ganglia in the brain. We're not really yet so good at having a diagnostic test for this mast cell activation syndrome, where it's still pretty much a diagnosis based upon history and presenting problem as opposed to having some hard data, right? The data you've described, but you touched upon something earlier that I'd like to go back to in terms of, we always try and give in these root causes of mental health podcasts, we try and give our viewers hope. There is help for them. What are some of the treatments? If you can start giving some of the names, some of the medications, and maybe some of the protocols. Let's say they have autoantibodies to dopamine 1 receptors or dopamine 2 receptors or tubulin proteins in the brain, the sorts of antibodies that Moleculera tests for. What are some of the treatments that can really attenuate these antibody levels and reset the immune system? If you could talk us through that.
Yeah, the categories that they fall into, and I'll give you some general categories and then some specifics. When you identify and understand and know that the patient is an immune-mediated neuropsychiatric disorder, typically they fall into, say, 3 or 4 categories. You can give anti-infectives, and we'll talk about that in a second, because there's a stimulatory underlying agent of the immune system. And usually we find that there's 1 or 2 or more infectious agents, and they could be subclinical. So we had cases where, let's say, a 7 or 8-year-old young girl suddenly develops these phobias and food restriction fears, wanting to jump out of the car while it's driving, saying, "Mom, something's wrong with my brain. I can't think." And testing them early, finding out they have these autoimmune antibodies, they did notice and understood and found an underlying infection. In fact, this was a subclinical strep infection. They treated her with azithromycin, and within 3-4 days or so, her symptoms abated, and they continued to treat her, and she stayed healthy because her immune system wasn't primed so much that she had a real strong memory B cell response. So that falls into the anti-infectives. And typically, if they're positive for these autoantibodies, you do want to look for, is there an underlying subclinical infection? And more often than not, we find that there's more than one. The second category is anti-inflammatory agents. And because remembering that the immune system and the cytokines are pro-inflammatory in meaning they're trying to recruit these other cells to the specific parts of the body, in this case, the brain, often these inflammatory agents, you mentioned methylprednisolone, as a steroid, which is very effective in doing that. And so sometimes they'll give them steroid bursts. And if they respond very well to them, sometimes they'll do this in sequence. But an interesting, and I'm not advocating this as a medical practice either, but one of the physicians that we work with says that about 1/3 of the patients that these antibodies are positive and they identify this as an immune-mediated syndrome, they do a course of ibuprofen, any other NSAID, and see if there's a response. And he said about 1/3 of them will respond for the period of time, the 2 to 3, 4 hours. And it confirms for them that this is the right course. They need to be doing something in this area. The third area and category is immune modulators. And these typically fall into anything that will modulate the immune system. And in the allopathic medicine side, the prescriptive components, which are intravenous immunoglobulin, plasmapheresis, which is removing the antibodies from the blood and then putting back the blood cells, and then even cancer drugs like rituximab that actually clear out all the B cells. And so one publication that was published, not by us, but a physician, an immunologist at Children's Hospital, I think it was maybe Cincinnati Children's Hospital, one 17-year-old girl was diagnosed with schizophrenia. Treatment-resistant olanzapine, was literally getting ready to be put in an institution, and she might have been in and out of it previously. They brought in an immunologist. He ran the test and found the autoimmune antibodies, treated her with IVIG and plasmapheresis, and in this publication, he said in 2 weeks she was back home playing tennis off of olanzapine and back to normal, and then read the report and asked him if he could send us a blood specimen. We tested it and found that all our antibodies were back to normal. So they will fall into those anti-infective, immune modulatory, and anti-inflammatory. Now, there's also the naturopathic component where about 20%, 25% of our formulary in the pharmacy arose from natural products. Any acetylsalicylic acid came from the willow bark. Many of the other vincristine, vinblastine from the periwinkle, all the opioids from the opioid poppy, and all the narcotics. So there's a lot of those that are used with people who know how to use them, but they do fall into those three categories. And then the fourth is the symptomatic treatment, because these SSRIs and other medications at low doses, because you do need to manage the patient and the symptoms. And I'm sure you're very familiar with that. And at standard doses, often they just even can get worse. But the lower dosages can help manage the symptoms while you treat the underlying root.
Yeah, what a great story you told there. We have one like that as well, where it was, let's just say, a young person who had depression and anxiety and severe OCD really getting in the way of them moving forward from high school into college. And we got them somewhat better with a combination of psychotherapy and two different antidepressants combined to modulate different neurotransmitter systems, and a little bit better on some celecoxib, COX-2 inhibitor, anti-inflammatory. But what really helped them the most was IV rituximab, which really, that combination plus what we were doing really helped them get launched off to college. And, you mentioned anti-infectives and these comorbid infections. A lot of the Lyme literature reports that as well, that not uncommonly, if you have one tick-borne microbe, you might be pretty likely to have a second or even a third, and a role for antimicrobials there as well. Where do you see the future of all this going? I know, you're a pioneer and Moleculera is pioneering. Can you share with our viewers where you think this is going? Again, trying to bring some more hope for those who are suffering chronically.
Yes. The hope obviously is that these will become standard practice and recognized and early detection. Some of the thoughts that we have are, even though we have this blood panel that can be tested, and it takes about between 1 to 3 weeks to process, because these are rare biological targets and radioactive assays, that in the future we could have a point of care test where a patient could present in a doctor's office with these symptoms. And you could be able to then take a pinprick of blood and identify whether or not there are specific types of antibodies that are present before deciding which pathway to go on at the outset. And that's one of the areas in which we are working on. The second is, how can we predict better which treatments will work more efficaciously when they are diagnosed? And we have over 15,000 patients in our biorepository and bioinformatics database, and of the treatments with other things that they've had. And so we partnered with an AI company to help us figure out which patients will respond with different characteristics to different medications versus a trial and error as they're trying to figure out what therapies work. And then to your point about where do you see this going, I think you've even used the example when we look at maybe peptic ulcers, several decades ago, thought to be just stress, and look at reducing acid in the stomach, when the notion of an infection triggering this, Helicobacter pylori, which was not received and not very well understood. Fast forward a lot of years and a lot of demonstration and a lot of people getting well, it's common practice. You present with a peptic ulcer, you look for antibodies to Helicobacter pylori, you get an antibiotic, and the patient, off on their way, versus the suffering for a long time with this pain. And so the goal, and again, your organization being at the forefront in this as a root cause psychiatry. And I really do want to commend you about that, because I did, as we go into these medical conferences and talk to other physicians, and talking to another psychiatrist, he said, Craig, we weren't taught to look for the underlying root and try to cure it. We were taught, how do we best help them cope with the situation they got and provide medications to allow them to function as much as well as they can. So the term root cause psychiatry is such an important piece. Let's get to the root of the underlying problem. let's treat the underlying problem. Let's deal with the symptoms, but recognize that we can bring hope and healing to patients who are suffering with these disorders that often they've given up. And many times we have seen, unfortunately, some individuals taking their own life because of the lack of hope in that they don't believe that there's an answer and can't get better. And so the goal would be, how do we circumvent that? And how do we provide that hope so that patients can know there's an answer? And of course, not all the answers are this, but we know a large portion of it is, and it hasn't been recognized.
That was beautifully stated, elegantly stated. And I would just add that it would really help these patients if family members, friends, or doctors they see don't dismiss them or don't try to really listen and try and understand and have compassion and empathy for their symptoms and their trouble functioning, because of course they'd like to feel normal and have their life go on and are unable to. As you were talking about the artificial intelligence company that you're working with, there's an enormous opportunity for AI to help all of us, help our patients here. We're developing an AI agent that will be an enormous help to our patients. It's already been trained in, if I read a journal article a day for 50 years, this agent we've developed has already read more articles than I could read in 50 lifetimes. And so with that and being able to train it and a lot of medical data, we really hope it'll help us help our patients more. And it sounds like you're going down that road as well. I think, the beauty of the world today is this explosion in knowledge to help patients, right? And then how do we harness all that knowledge in a way that we can use it day to day to really help our patients? And I really want to congratulate you and Dr. Cunningham on your pioneering work. You've really inspired me. You've opened my eyes and the eyes of my colleagues at Potomac Psychiatry to the role of infectious diseases in many patients with chronic mental health problems. And please keep up your good work. And I'm deeply grateful to you for what you do and for joining me today. You're an incredibly busy guy. I know you're out finding investors to carry on your great work. And I wish you all the best of luck in that. And really, please give my best to Madeline as well. Thank you.
Thank you, Dr. Bruce. I appreciate that. And maybe what I'll do is leave with one comment. I think it was a quote by Dr. Sidney Baker, who is part of the Defeat Autism Now, who said, if you're sitting on a TAC, the treatment for TAC sitting is not 2 Advil every 3 to 6 hours. If you're sitting on a TAC, the treatment is TAC removal. And if you're sitting on 2 TACs, removing 1 TAC doesn't alleviate 50% of the symptoms. So you have to actually look for the root, treat all the conditions. And this is part of the complication of this multifaceted disorder, is identify the root, treat the root, and usually it's with an S, roots, infection, immune system, inflammation, and you can see remarkable results. So I too am thankful for the work you're doing, because you're at the front line taking care of these patients. And I look forward to more continued interaction with you and your group.
Thank you so much.